I know the diagnosis sometimes, but I still choose the wrong answer. What am I missing?
You may be treating the question like a fact-matching game. Many medical exam questions are not asking which answer is a true statement. They are asking which answer fits this patient's situation right now. That difference matters. One answer can be true later. Another can be true in a different setting. A third can describe the right disease, but the wrong next step. The exam rewards the answer that fits the main clinical story. So this episode is not a list of tricks. It is a way to read the STEM. The goal is to find the task, the setting, the level of urgency, and the stage of care before the answer choices pull you away from the story.
So the exam is not just testing whether I know the disease.
Exactly. Disease recognition matters, but it is only the entry point. A stronger test taker asks a second question. What does this patient need now? The same disease category can appear in different clinical moments. In one question, the patient needs stabilization. In another, the patient needs a diagnostic test. In another, the diagnosis is already established, so the question is about initial management, definitive treatment, prevention, counseling, or follow-up. That is why two choices can both sound medically correct. The issue is not always which one is more true in the textbook. The issue is which one belongs to the clinical moment described by the STEM. A useful phrase is right patient, right setting, right time. If an answer fails one of those three, be careful, even if the answer sounds familiar.
What do you mean by the main clinical story?
It is the short headline that explains why this patient is here and what decision has to be made. Do not let a single clue become the whole question. A lab value, a risk factor, a medication, or a classic symptom may be important. But the main story usually combines several things: the setting, the time course, the patient's stability, the last line, and the stage of care. Before you commit to an answer, pause for one sentence. This is a patient in this setting, with this level of urgency, and the question is asking this task. If that sentence is clear, the answer choices become less noisy. If that sentence is not clear, you are more likely to chase a keyword. Keyword matching feels fast, but it often chooses a true fact that does not fit the patient.
What should I check before choosing?
Use 5 checks. First, the task. What is the last line asking? Diagnosis, mechanism, next best step, risk factor, complication, prevention, or management. Second, the setting. Is this the emergency department, an outpatient clinic, a hospital ward, the operating room, a follow-up visit, or a screening visit? Third, stability. Is the patient unstable, or is there time to think deliberately? Look for the things that change priority: airway, breathing, circulation, mental status, severe pain, dangerous vital signs, or rapidly worsening symptoms. Fourth, the stage of care. Are we stabilizing, diagnosing, starting initial management, choosing definitive treatment, preventing disease, counseling, or following up? Fifth, the answer. Only after those checks should you compare choices. Otherwise, the answer choices can set the agenda for you.
Why does urgency change the answer so much?
Because some clinical moments punish delay. In an emergency frame, the question may not reward the most elegant diagnosis first. It may reward the action that makes the patient safer before the workup continues. Imagine an original teaching example, not a real exam item. A patient arrives in the emergency department. The STEM gives clues that suggest a diagnosis, but it also tells you the patient is confused, ill-appearing, and physiologically unstable. One answer choice offers a confirmatory test. Another offers a long-term plan. Another focuses on outpatient follow-up. Those ideas may be medically reasonable somewhere, but they do not match the moment. In that kind of STEM, the main story is not, can I name the disease? The main story is what must happen before we can safely continue. Stabilize first, then refine. This is not a rule that diagnosis never matters. It is a sequencing rule. Diagnosis matters, but in an unstable patient, diagnosis has to take its place behind immediate danger.
What changes if the patient is stable?
Now the logic can reverse. Imagine a stable outpatient with symptoms that developed over weeks or months. The vital signs are reassuring. There is no immediate threat to life. The last line asks for the next step. In that setting, jumping to treatment may be premature. The best answer may be the test that confirms the diagnosis, the screening step that fits the risk profile, or the follow-up plan that safely narrows the problem. This is why you cannot choose by disease name alone. The disease category may be similar, but the clinical task is different. In an unstable emergency, diagnosis may come after stabilization. In a stable clinic visit, diagnosis may be exactly what the question is testing. A stable frame often rewards precision. It asks, what information do we need before acting? Or, what is the safest next step in a patient who is not crashing?
So after setting and stability, I should identify the stage.
Yes. The stage of care is one of the highest yield ideas in exam reasoning. If the question is at the stabilization stage, do not jump to a beautiful confirmatory test. If the question is at the diagnosis stage, do not jump to definitive treatment before the diagnosis is established. If the diagnosis is already clear, the exam may be asking initial management, definitive management, complication monitoring, prevention, counseling, or follow-up. Many wrong answers are not absurd, they are simply out of sequence. The answer may belong to the same disease, but a different point in the patient's journey. When you are stuck, ask, where are we in the patient's journey? Before diagnosis, immediately after diagnosis, after initial treatment, during follow-up, during counseling. That question often removes the most tempting wrong answer.
That explains why wrong answers can feel so tempting.
Exactly. Good distractors are often true facts placed in the wrong moment. A test may be useful, but not before stabilization. A treatment may be effective, but not before the diagnosis is clear. A risk factor may be real, but the last line may be asking for management. A complication may be associated with the disease, but the patient's current presentation may point somewhere else. There are 4 common traps. First, the right disease but the wrong task. Second, the right task but the wrong urgency. Third, the right treatment but the wrong stage. Fourth, the right association but not the main reason for this presentation. So do not ask only, have I heard of this? Ask, does this answer fit the task, setting, stability, and stage?
Should I read the last line first?
Many students find it helpful, but the last line alone is not enough. The last line tells you the job. The stem tells you the situation. If the last line asks for the next best step, you still need to know whether the patient is unstable, newly diagnosed, already treated, or at a follow-up visit. If the last line asks for the most likely diagnosis, then management choices may be distractors. If the last line asks for mechanism, then a treatment that feels clinically important may not answer the task. So use the last line as a compass, not as the whole map. Read it early if that helps you. Then read the stem to decide what the compass is pointing toward. A practical move is to cover the options mentally and predict the category of the answer before reading the choices. Not the exact answer, just the category. Stabilize, test, treat, prevent, counsel, or follow up.
What if 2 answers both look reasonable?
Then compare them by timing, not by emotional comfort. Ask which answer changes the patient's immediate course in the scenario you were given. If one choice is a test and one is a treatment, ask whether the diagnosis is already established. If one choice is acute care and one is prevention, ask whether the patient is in danger now. If one choice is definitive therapy and one is initial management, ask whether the patient has been stabilized and fully evaluated. This is where depth matters. The exam is not asking you to admire every medically true choice. It is asking you to choose the next appropriate move in one clinical sequence. When you cannot decide, eliminate the answer that is true but out of sequence. Then choose, mark if needed, and move on. A hard question should not steal the whole block.
How do I use this under time pressure?
Turn it into a short mental checklist. Task, setting, stability, stage, answer. Do not make it a long ritual. It should become a fast scan. Also, practice with official materials and the interactive testing experience for your exam. You are practicing content, but you are also practicing the software, timing, and rhythm of moving through questions. Exam day rules, block formats, tutorial time, break time, identification rules, and test center rules can change. Check the official instructions for your own exam date. On breaks, follow the official break screen and test center rules. Do not rely on memory from another person's exam day. The goal is to reduce avoidable friction so your attention stays on the question in front of you.
What is the one rule I should remember?
The best answer is the one that fits the clinical moment. Do not ask only which option is medically true. Ask which option fits this patient in this setting, at this level of urgency, at this stage of care. Read the story, name the task, find the priority, then answer the moment. Consistency matters more than brilliance. If you use the same process on every question, you reduce the mistakes that come from panic, keyword matching, and jumping out of sequence.